Mark your calendars for RSNA 2024, Building Intelligent Connections. Join us in Chicago for the biggest week in radiology from December 1st through the 5th as we explore how to intentionally and intelligently build the right connections between people and technology, expand your network, elevate your skills, and navigate the changes shaping medical imaging. Registration opens July 17th. Go to rsna.org/annual meeting.
Welcome to RadioGraphics podcast. My name is Andy Chesley, and I'm an interventional radiologist at the University of Texas Health Science Center in San Antonio, Texas. To jump right in, much attention has been paid to acute venous thromboembolism, with a particular focus in the pulmonary embolism space, especially with the changes in recommendations regarding mechanical thrombectomy versus catheter-directed thrombolysis. Interventions in the non-massive pulmonary embolism patient are principally to prevent the subsequent development of chronic thromboembolic pulmonary hypertension. A recent paper published in October of 2022 was titled Balloon Pulmonary Angioplasty in the Management of Chronic Thromboembolic Pulmonary Hypertension and was written by Drs. Higuchi, Horinuchi, and Aoki, amongst others, and is particularly relevant as it details the role of the interventionalists in management of long-term sequelae of incompletely removed acute pulmonary embolism. Chronic thromboembolic pulmonary hypertension, or CTEPH, is a complication of pulmonary embolism characterized by the transformation of incompletely resolved thrombi into fibrous tissue that occludes the pulmonary arteries. It falls under Group 4 pulmonary hypertension in the 2015 European Society of Cardiology and European Respiratory Society guidelines, or in other words, pre-capillary in etiology. The established curative therapy for CTEPH is pulmonary endarterectomy, which provides favorable long-term outcomes with low mortality rates. However, for patients with inoperable disease or those with residual or recurrent pulmonary hypertension after endarterectomy, an emerging alternative treatment option is balloon pulmonary angioplasty, or BPA. BPA has been reported to improve hemodynamics, cardiac function, exercise capacity, and symptoms in this subset of patients. It offers a potential solution when endarterectomy is not feasible or when patients experience persistent pulmonary hypertension despite surgery. However, while the potential benefits of treatment are significant, angioplasty in this sensitive territory can lead to life-threatening complications. Physicians, particularly interventionalists and radiologists who work in centers that focus on CTEPH, should be aware of the indications and methods of balloon pulmonary angioplasty. Understanding the disease process is important. CTEPH is likely underdiagnosed and undertreated, with a reported occurrence of up to 6% after pulmonary embolism. Diagnosis is currently made based on the satisfaction of 3 criteria. 1. Elevated pulmonary arterial pressure with a normal wedge pressure. 2. Imaging findings such as VQ mismatch or stenoses on cross-sectional imaging. And 3. The above findings after at least 3 months of medical management. Symptoms are nonspecific but develop around a year after the initial insult, with exercise intolerance, dyspnea, and shortness of breath being common. The current treatment of CTEPH includes lifelong anticoagulation with either endarterectomy, pulmonary hypertension-directed medical therapy, or balloon angioplasty. While endarterectomy does offer the best chance of improved long-term outcomes, pulmonary endarterectomy also requires a not insignificant intervention, involving a thoracotomy and hypothermic circulatory arrest. As such, many patients with comorbidities and lesions not accessible to surgical resection are not candidates for surgery. Unfortunately, this ends up being true in approximately 1/3 of patients. Furthermore, up to 30% of patients demonstrated residual pulmonary hypertension after surgery due to unresected disease from inaccessible distal branches. Patients with unresectable or residual disease may go on to treatment with pulmonary hypertension-directed medication, though patients treated with these medications may have poorer prognoses than those treated with intervention. In such situations, catheter-directed therapy offers an alternative. Balloon pulmonary angioplasty is both less invasive and capable of reaching lesions that may be too distal for open endarterectomy. Persistent lesions after open resection are also indicated for treatment with angioplasty. As such, cooperative treatment plans of open endarterectomy and reinforced with balloon angioplasty has the best chance of achieving long-term success. When planning for intervention with balloon angioplasty, multimodal imaging is necessary to accurately identify clinically important lesions. Planar ventilation perfusion, or VQ scans, remain the first line imaging in diagnosis of CTEPH, identifying hyperperfused segments without more invasive measures. However, VQ scans do not provide information on the vascular lesion underlying the perceived disease. Cross-sectional imaging with SPECT-CT or MR angiography can aid in identifying the culpable lesions, though CTA remains the most important tool in lesion characterization and treatment planning, principally due to the high resolution compared to the other cross-sectioning modalities and the ability to view the lesion of interest in any projection. This is particularly helpful when preparing for interventions, as projections for DSA may be planned for ahead of time. Identification of lesion-specific projections both reduce the procedure time as well as radiation dose to both the patient and operator. For treatment day, the authors prefer a femoral approach for right heart catheterization due to the decreased radiation exposure to the operator when compared to the jugular approach. An 8 French sheath is used for initial access, followed by pulmonary artery selection with a balloon wedge catheter. Once the pulmonary artery is selected, the wedge catheter is removed in exchange for a 6 French long sheath. The targeted vessel is then selected with a 6 French MPA catheter. The authors note that selection of the ventrally oriented vessels, such as A3, A4, and A5, are often more readily selected with a modified Judkins left catheter. Once the guiding catheter is in place, access across the lesion is obtained with an 014 non-hydrophilic wire, followed by balloon angioplasty with a small 2 to 4 mm semi-compliant balloon. As vessel size is often greater on follow-up imaging than even immediately post-dilation, repeat angioplasty with a larger balloon is not recommended during initial treatment. Occasionally, dilation with a larger balloon is performed during follow-up treatments if the vessel remains stenotic, however. While most interventionalists are comfortable with balloon angioplasty, the pulmonary arterial system presents a unique challenge. Selection of appropriate targets is key for safe and effective treatment. Lesions are classified by their characteristics, with ring-like stenoses, type A, and web lesions, type B, being lesions that are more readily treated. Subtotal occlusions, total occlusions, and tortuous lesions, types C through E respectively, represent more challenging targets from both a technical and complication standpoint. Easier lesions should be targeted earlier in treatment course due to the high risk of vessel injury in challenging lesions. More challenging lesions may be approached later in treatment after an acceptable decrease in mean pulmonary arterial pressure is achieved. Treatment response is based on the concept of regional pulmonary blood flow, a scoring system similar to the TICI system used in stroke work. Grade 0 represents no perfusion, or penetration with minimal perfusion of the pulmonary arteries. Grade 1 corresponds to partial perfusion of the pulmonary arteries. Grade 2, complete perfusion of the pulmonary arteries and partial perfusion of the pulmonary veins. And Grade 3, complete perfusion of both pulmonary arteries and veins. An endpoint of each session is not well standardized, though improved flow in 2 to 3 pulmonary segments is suggested. Treatment is usually separated into 3 to 10 sessions due to the risk of reperfusion pulmonary edema. Between 2 to 6 lesions in 2 to 3 segment branches are targeted per session, with a total of 10 to 15 branches treated at completion. Despite the benefits of intervention, complications remain somewhat frequent at almost 36% of treatments, principally reperfusion pulmonary edema and vascular injury. Pulmonary edema was noted to occur in as high as 60% of interventions in older studies. This is notable as severe pulmonary edema often requires intubation and ventilation, while mild and moderate edema may be effectively managed with CPAP or high-flow nasal cannula. This led to the adoption of the above-described stepwise approach, where vessels are underdilated in earlier sessions and then dilated more appropriately in later sessions. This fortunately resulted in a significant decline in severe pulmonary edema. Recent studies suggest an incidence of up to 7% of severe reperfusion pulmonary edema. Of note, independent predictors of edema include baseline high pulmonary arterial pressure, first session of treatment, low cardiac output, high BNP, and underdeveloped bronchial arteries, suggesting the need for a complete workup prior to treatment to identify high-risk patients. On the operator's side of complications, vessel perforation is the most common injury, occurring in about 7% of treatments. Vessel rupture after dilation is thankfully more rare, at about 1% of interventions. but is critical and can lead to massive hemoptysis and even death. The risk of vessel injury is greatest in the tortuous vessel lesion morphology at nearly 43% of dilations, and is still remarkably high in subtotal occlusions at 15% of dilations. Total occlusions, web lesions, and ring-like lesions were significantly less likely to be injured during dilation at 6%, 2.2%, and 1.6% respectively. After bleeding occurs, it is more likely to be severe in patients with an increased mean pulmonary arterial pressure. Prolonged inflation of the balloon is often successful at sealing the perforation, but if embolization is required, then gel foam is preferred, due to being both effective and temporary and allowing access to the injured vessel during subsequent treatment. Severe hemorrhage may be poorly controlled, however, with gel foam, and often requires a more permanent embolic, such as coils, to achieve adequate hemostasis. This is not preferred, as embolization is then permanent and can worsen the patient's underlying disease. Vessel dissection is also described, occurring in up to 7% of cases, though have been found to be self-limited if the procedure is halted at the time of discovery. While effective, the role of balloon angioplasty is still being elucidated. A recent World Symposium on Pulmonary Hypertension proposed new definitions of all precapillary pulmonary hypertension. While the new definitions have not been applied to CTEPH directly, the criteria for CTEPH may change or necessitate higher goals in management. Standardization of treatment procedure and technique, along with associated training standards, will be necessary to promote balloon pulmonary angioplasty worldwide. Additionally, the role of angioplasty in patients with otherwise resectable disease but refuse surgery has not been completely investigated. Finally, long-term outcomes when compared to endarterectomy are poorly understood, and randomized multicenter trials are certainly needed to further elucidate this relationship. Ultimately, CTEPH is a challenging disease from both a symptom and treatment perspective. Balloon pulmonary angioplasty is a novel treatment, effective at increasing exercise tolerance, cardiac function, and symptoms in patients with unresectable disease or persistent symptoms after endarterectomy. A thorough understanding of the anatomy, physiology, technique, and associated complications is necessary in appropriate treatment of CTEPH with balloon angioplasty. While I enjoyed summarizing, please take a moment to read the entire article in the October 2022 edition, which is definitely worth the effort, as it is complete with images as well as videos demonstrating the best projections on DSA and tools for effective catheterization. Thanks again for your time. Don't forget to like and subscribe so that you don't miss any future editions of the RadioGraphics podcast.